You know, you alluded to this, Angela, already, that, you know, a lot of the discourse we're hearing actually centers on vaccine hesitancy. We hear a lot about vaccine hesitancy. But if you can expand a little bit more on those structural factors that are at play when it comes to reasons for hesitancy in communities you've heard from and are working in. So I'll pose this to all three of you, really, but perhaps start again with Angela here. Just mix things up a little bit for you here, Angela, but because you spoke to it, I think it's a really important part that we flush out and tease out a little bit. Like what are some of those factors at play that can lead to people, you know, not accessing vaccine?
So happy to weigh in, and I know that you know, there's a plethora of other examples and perspectives. I guess I would begin by framing and being clear that that hesitancy is very different than anti-vax. Yeah. So, you know, I come from, you know, Jamaica as an immigrant to this country. And I remember, you know, my mother trotting me and my sister out to get, you know, our little jabs, our immunizations. So I always laugh that, you know, we all have the mark to show that we are open to, to vaccination. So really wanting to make that distinction. In terms of, I think that to address the specificity of the question around what gives rise to hesitancy is, I think we need to know and always remember that there are historic and contemporary examples whereby racialized folks, low-income folks, immigrant communities, indigenous peoples have not fared well in clinical research, and that in fact there are historic examples whereby Black folks, indigenous folks, people with disabilities have been used in clinical experimentation and clinical, in terms of scientific research, whereby there wasn't appropriate consenting, where in fact the research, we look at Tuskegee and the syphilis public health experiment in the US, which ran for several years. I think over 25 years, whereby there was consenting, there was mistruth spoken, and even though that that did not happen in the context of Canada, is that it has far-reaching implications for us wherever we are. And we know that there have been instances of forced sterilization. We also know, even if we go further back, whereby we know that in the moment of slave trade, the experience of Black populations in the diaspora in slavery is that there was Black bodies used as experiment subjects in a range of horrific scientific endeavors. So there is the historical examples that Black folks know of and can speak to about the ways in which we were used in what I would say were racist experimentation. Then we also have the contemporary examples of how Black, racialized, low-income folks, indigenous folks experience the healthcare system, and which leads to a real lack of confidence and a lack of trust. And, you know, we have the experience just the other day of our sister, Indigenous sister, Joyce Echaquan in the hospital there in Montreal. So we don't have to look far for these examples that create justified mistrust in the healthcare system, and the fact that, you know, earlier on in the deploying of the vaccine, there was some conversation and some strategy about how we would use the continent. You know, Africa is a big place, but it was framed that we would use the continent basically as a bit of a first rollout to see how was this going to work. So all of those things, I think, anchor themselves in communities to say, really, we don't know if you have our best interest at heart, and therefore it leads to what I call healthy mistrust and or healthy questioning, and that then puts the responsibility and the onus on the part of the healthcare system to speak to that mistrust and to not deny the reality that lead to that site of mistrust, but to speak to that, to acknowledge that, and then to bring the science of how these vaccines were developed that can enliven confidence. So those would be some of the things that I would say are rooted in why there are these sites of mistrust that can lead to this thing called hesitancy.
Thanks, Angela. I think that's so important, because when we talk about hesitancy, often we hear, you know, the way to overcome that is just more information, more scientific information. And we know it's about far more than that. It's about relationships and trust and acknowledging these injustices. Sume, does that echo what you've been hearing in the research you've been doing?
No, absolutely. And I think as Angela's highlighting things like the Tuskegee syphilis experiment, one of the key things to remember that experiment ended in the 70s, right? In the early 70s. So we have people alive today who remember it as a visceral part of growing up. For a lot of us, I think Tuskegee laid the foundation for medical ethics as we know it today, right? So if you did like early research, you may have learned about that in school, but for a lot of communities, it's still very acute, alongside the Tuskegee syphilis experiment, which, by the way, was funded by the federal government, right? It was a state-led study. We've also had examples of Henrietta Lack, who was an African-American woman, again, to Angela's point about how these stories travel really across the globe, whose cells were used for cancer experimentation, and she died of cancer without her consent, right? And she herself died of cancer. That research went on to generate billions and billions of dollars for the researchers and for the companies involved. Her family till this day has not been compensated. And that happened in the 50s. So these are very recent stories. So these are definitely coming up in conversation. The other one thing I want to flag is in COVID-19, there has been active disinformation, not just misinformation, right? Which is, I think, for a lot of us, COVID is new. Every day there's a new bit of information about COVID, specifically about the vaccines too. But alongside, there's been an active campaign of disinformation, which started at the very beginning, and a lot of this has been led by white nationalist groups, right? So it's not by accident. And what I've seen is folks trying to like acknowledge that disinformation is there, and also making the connections for people to say, to Angela's point, they are, anti-vaxxers to say, but people who really have a deep issue with vaccines generally. But I think in Black communities where I'm speaking with, and even in my own life, it's not like we don't trust vaccines, but healthy mistrust, as Angela was saying, and a questioning. Again, if we think about the COVID-19 response broadly, it has not, for the mainstream public health responses have not prioritized Black communities, have not necessarily prioritized low-income communities, people with disabilities. Claire, you mentioned the early work we did. We heard that loudly when we spoke to folks, and I'm sure a number of you have been with us since last year in this journey of exploration. Like, we keep hearing that for communities at the margins, their needs are not being prioritized. So when you come to COVID vaccine response, it's like, okay, we've been at this for a year. We haven't really seen any dedicated focus from mainstream public health. So why all of a sudden should we trust that the vaccine is really there to serve us? And I think what the work communities have been doing is acknowledging that reality and acknowledging the reality of anti-Blackness in the health system, and then building that trust of the vaccine, creating those pathways to care and access, which I know we're going to talk about in a little bit.
Thanks, Sume. Stephanie, what have you been hearing from Indigenous communities in the work that you've been doing?
Yeah, thanks, Claire. No, I think Angela and Sume touched on a number of points that hold true for Indigenous communities across the country. I just wanted to build on what Angela was saying about the historical and contemporary experiences, and I mentioned that earlier as well. For Indigenous people's concerns surrounding the COVID-19 vaccine need to be explored within those historical and current experiences of inequities, historical traumas that stem from vaccine experimentation that have also been occurred among Indigenous peoples as well, residential schools, colonization, which has resulted in intergenerational challenges. And so we've seen this experienced across communities. And as Sume had mentioned, I mean, there's recollection of those events, right? And so there are Indigenous peoples members and communities that remember those past historical harms. And so a lot of that has brought up some discomfort and uncertainty, fear and anxiety among Indigenous peoples today. With just in general, throughout the pandemic, but definitely so with the vaccination rollout. Mistrust, I think, is really important here as well. Angela touched on, when we talk about contemporary experiences with the health system, there's been a number of stories that we've heard over the years of experiences with racism and discrimination in the healthcare system. Angela gave the example of the death of Joyce H1n1, who had experienced abuse by healthcare workers. And so when we're going to be talking about strategies and what works best to overcome some of those fears and concerns in a little bit here. And so I look forward to sharing some of that, what we've learned. The other thing I wanted to touch on too is what does this bring to the forefront in terms of values? Right. So I think this shows a misalignment of values between policy and decision makers, health system leaders, and communities. I think that connects to what Angela and Sume had mentioned around prioritization. That certainly came up in our conversations with key Indigenous experts, where in the past, historically, Indigenous communities were not prioritized, but we saw them being prioritized during the vaccination rollout as a group that was at greater risk. So, that brought about some questions around Indigenous leaders with respects to that. Another example too around past experience is, when we look at past pandemics or epidemics and what that experience has been like for Indigenous peoples. One example I thought I'd highlight here is the H1n1 example. So the disturbing example that had occurred during that outbreak where the federal government sent body bags to 4 Manitoba First Nation communities instead of shipments of antivirals, hand sanitizers, flu kits, et cetera, or other resources. So that serves as an important lesson for us to think about. And certainly that example has played out a lot throughout the COVID-19 pandemic as an example that we don't want to repeat. But to serve as a lesson for us to what not to do in how we continue to support communities and populations most at risk. The other thing I just wanted to highlight is, and both Sume and Angela mentioned this, is the relationships, and that's really key here too. Again, with the number of crises that we've seen disproportionately affect Indigenous communities, not just in our home province here, Clare, Alberta, but across the country. So over the past decade, whether we're talking about the H1n1 epidemic, the 2013 flood here in southern Alberta, or the 2016 wildfire in northern Alberta, and the opioid epidemic, and now of course COVID-19. With each of these public health disasters, it's brought into question the relationship and respectful relationships and coordinated efforts between the federal and provincial and own reserve governments. And so that relationship between those different parties is really important here in terms of where mistrust might be present as well. And in looking at those examples too, one point that I wanted to just highlight was that there has been a constant rebuilding of those relationships each time these public health emergencies or crises happen, and it does delay any of the efforts and relating to that public health crisis, whether we're talking about the vaccine rollout or in general supporting communities during this difficult time.
Thanks so much, Stephanie. I've been doing some key informant interviews with folks who work with individuals experiencing precarious housing or homelessness. And certainly these same themes emerge amongst that group as well. And in terms of the mistrust, the poor experiences with the healthcare system, and even when being prioritized, mistrust in that prioritization. One participant said a patient she was working with and like in the middle of the vaccine appointment, and he was kind of like, you know, no one's ever cared about me before. Why am I first in line? Like, is that because it's bad? Like, he's never had a good experience with the healthcare system before. And so I think that there's, you know, some really personal and terrible experiences that folks have had and yet are still stepping up. They still want the vaccine, but there's a lot of mistrust to overcome in that.
Yeah, and just picking up on that for me, Claire, it's you know, I've seen the same thing here where in terms of with unsheltered populations and racialized populations in and areas of the city where we have a higher proportion of racialized populations who are also folks who are lower income, is folks being very mindful and very suspect of the overture around bringing vaccine, because sometimes what that gets tainted with is that homeless folks, because of the precarity of their accommodation, is that they're moving across the city, and therefore that's sometimes what I think we saw at the beginning was some of the language around we need to get these people immunized because they're somehow seen as the vectors of disease. Yes, so based on the precarity of their housing situation, is they will be quite mobile, and therefore we need to, not that we need to get ahead and protect the lives of homeless folks, but we need to immunize homeless folks so they don't become a health risk for the general public. So we've seen that. We've also seen a similar kind of suspect and justified questioning from racialized populations as well, and some of the narrative around how vaccine get brought into these communities with around these are the groups of essential workers. These are the workers on the front lines. So one, these are the workers who we need to keep healthy. So it's not necessarily about the lives of those folks, but we need to have them as a reliable workforce. So that's one. And then two, it's a kind of a casting that if we don't control COVID in these areas where there are higher rates of COVID, because folks are lower income, they may be living in family units where it's harder to isolate, their work condition doesn't enable them to work remotely. So so they're out in the many public spaces, is that those community members have justifiably felt that at times vaccine isn't coming into their communities because there is valuing of the lives and the safety and security of those community members, but because the community pose a risk. If COVID isn't controlled and contained in those communities, then they pose a risk for the general public. And when we talk general public, I love the euphemism, of general public, because the euphemism of general public usually mean white folks. Yeah, so we need to be clear that when we talk about the general public, we're often talking about the spaces where white communities live largely and or where dominant populations live largely that need to be protected, that need to be secured. So I really love, you know, the fact that we're having these conversations, because we also get to unpack and name the things that get framed in these euphemistic ways, and so yes, in terms of to your comment about how vaccine can be enabled in communities, but for the wrong reason. And you know, we can certainly begin to talk about how we enable that for the right reason. But I see Sume's got her her chat off, so it's begun.
Yes, Angela, and someone in the chat box is saying very powerful words, echoing that 100%. And I'm just thinking also about the global context. I'm hearing similar narratives as we start to talk about vaccine equity around the globe. A lot of it has been around, you know what, those variants are coming from insert country, usually countries in the global south. And so we need to, in order to protect ourselves in the global north, we need to get vaccines there, which is a very different conversation from saying that COVID-19 vaccines are essentially a global public good, and the public has invested in the development of these vaccines, and so we should ensure that their rollout globally is equitable in all the dimensions that you've already started talking about. So I think we're seeing exactly what you're saying in the Canadian context and also globally.
And to me, this conversation and what you said, Angela, really links, you know, the racism, capitalism, these structural determinants of health that interplay to create inequities. And it's been said a million times, but COVID has highlighted this and uncovered this and really showed us exactly where these structures are at play. I do want to, sorry, go ahead.
And just to comment as well around anti-Asian racism, yes, and how that also gets framed. So many of us remember SARS, yeah, and what happened in SARS, where Asian communities were particularly targeted, and we've seen some of the same things happening now, where Asian businesses are targeted, where Asian residents in our city are targeted as, again, vectors of COVID. And we remember, and it still is happening, but maybe because, you know, he doesn't have Twitter anymore, you know, the former president in the US, is the languaging of the naming and the branding of this virus, as, you know, as he stated, and others who followed him stated, around this China virus. That was the framing, which, you know, is a racist framing that then also targets, in terms of communities. We have, in terms of access to vaccine, we have seen a significant uptake when we go into doing vaccination in communities where low-income racialized populations live, and large numbers of Asian community members, residents live, is we've seen significant uptake of vaccine from those communities. And I often wonder around if part of it is also around needing to protect oneself, to push back against the narrative, because if a community member contracts COVID, and the contact tracing says it's Angela, who is a young Asian woman, not that I'm a young Asian person, but if it leads back to that, then it amplifies a whole different anti-Asian messaging. And I wonder if the community is also mobilizing to access the vaccine to also ward off against that racist blowback that happens if a member of that community is impacted by COVID, that could have a community spread implication.
Thanks, Angela. And Claudine here, one of our participants, also pointed out the anti-Asian sentiments that are embedded in this pandemic. And I think that's a really important consideration. Thank you for bringing that forward.